First, I would like to thank all the participants who have joined us today for this webinar. It is an honor to introduce our speaker, Dr. Tarik Benidir. Dr. Benidir is a clinical assistant professor in the Department of Urology at the University of Florida College of Medicine and a specialist in urologic oncology. Dr. Benidir's practice is dedicated to the advanced management of prostate cancer. In his practice, Dr. Benidir performs complex robotic surgeries and has a particular expertise in prostatic focal therapy, utilizing cutting-edge organ-sparing techniques such as high-intensity focused ultrasound, HIFU, cryotherapy, and irreversible electroporation to target tumors precisely. Dr. Benidir's ongoing research involves clinical trials in prostate and bladder cancer. He currently has two investigator-initiated trials. One involves the use of salvage HIFU for radio-recurrent prostate cancer. Another is focused on reproductive organ-sparing radical cystectomies in female patients with bladder cancer. Dr. Benidir completed his urologic training at the University of Toronto and then went on to complete subspecialty fellowship training in urologic oncology at the prestigious Cleveland Clinic. Please welcome me in joining Dr. Benidir as he presents today on prostate cancer risk stratification utilizing IsoPSA multiparametric MRI.
Thank you so much. Thank you to all the organizers and those viewing today. I'm really excited to talk to you guys about what I think has been a very helpful adjunct in my workup of patients with elevated PSA. Today we're going to talk about IsoPSA, the IsoPSA in terms of prostate cancer risk stratification, and how we can use that in a contemporary era with imaging, specifically multiparametric MRI, to really help us make very informed decisions for our patients. So these are my disclosures. I am a clinical advisor for IsoPSA, and the opinions presented today are my own. So the agenda today will be stratifying risk of clinically significant prostate cancer with multiparametric MRIs, and then how to utilize the information from a multiparametric MRI and specifically the PI-RADS scoring system, in addition to the IsoPSA result that you get, to have a conversation with your patient and make a decision that's in his best interest, but also makes clinical sense. We're then going to go through some clinical studies that have shaped the landscape of IsoPSA, and we're going to go through a couple of patient scenarios to really hone in on how to utilize these in various situations. So the NCCN guidelines state that in patients who present with an initial elevated PSA, that the first thing you must do is get a repeat PSA. And the reason why is that PSA has poor specificity for prostate cancer, and 25 to 40% of patients who have an elevated PSA on subsequent PSA, that will return down to normal. And so it's important to get two elevated values of PSA before you start going down the pathway of figuring out why from a cancer standpoint. You then want to perform a digital rectal examination and work up the patient for benign causes of elevated PSA. So that can include prostatitis, infection, manipulation, recent instrumentation, among others. With that information, if you have two elevated PSA values or you're concerned based on the DRE, you then want to perform a multiparametric MRI, or you can add an adjunctive test such as biomarkers, including IsoPSA, PHI, 4K score, among others. With the information from the multiparametric MRI and or the IsoPSA, you then have an idea of what is your suspicion for clinically significant prostate cancer. And if it's high suspicion, you want to move forward with a biopsy. So these are the NCCN classification guidelines for prostate cancer early detection in 2024. So stratification risk of clinically significant prostate cancer to inform biopsy with or without multiparametric MRI is the first step in making a decision for your patient. But first, before we go to the biopsy, we know that MRIs have drastically changed the landscape of how we manage our patients with not only a diagnosis of prostate cancer, but also elevated PSA. Beyond just understanding where a lesion is located, there's been much work in validating the assessment of lesions on MRI. And notably, PI-RADS version 2.1 score is a well-validated way of determining the probability of clinically significant prostate cancer. It's a score from PI-RADS 1 to PI-RADS 5. PI-RADS 1 and 2 are generally in an MRI invisible prostate, PI-RADS 3 is equivocal, and PI-RADS 4 or 5 are suspicious for clinically significant prostate cancer. Now, we know that the higher PI-RADS score that you ascend to, the more likely you are to identify clinically significant prostate cancer, increasing grade group, extraprostatic extension, seminal vesicle invasion, as well as biochemical recurrence. And so the higher PI-RADS scores are always associated with a higher risk for adverse pathology. Now, in 2018, when we looked at the PI-RADS version 2.1, you see that the probability of clinically significant prostate cancer, as mentioned in my previous slide, does increase with increasing PI-RADS score. 8% in PI-RADS 1 or 2, 15% in the equivocal PI-RADS 3, 36% in the suspicious PI-RADS 4, and 58% in the very suspicious PI-RADS 5. And clinically significant prostate cancer is defined as grade group 2 or higher prostate cancer. Now, up to 30% of clinically significant prostate cancer is not just found in the target, but is found either in conjunction with the target or alone on systematic biopsy. Now, as a urologic oncologist, mpMRI has drastically changed my patient counseling and also how I understand how to operate, how to target biopsies. And I get it in most men, if not all men, prior to any biopsy. It provides so much information based on the 4 sequences that are involved on size and function, where the lesion is located, where the index lesion may be, where other lesions may be burrowing, and what are those index and non-index lesion relationships to the urethra, rectum, sphincter, and neurovascular bundle. It certainly aids in the diagnosis because now that you're targeting a specific area, you're improving your chance of identifying clinically significant prostate cancer while reducing your chance of identifying indolent disease. And furthermore, it aids in the optimization of your targeting. And so if you have, for instance, a lesion in the anterior part of a prostate or straddling the urethra, you may want to employ a transperineal approach. Whereas if you have a lesion that is posterolaterally, you can either employ the transrectal approach or the transperineal approach. And so for those who are facile in both modalities, it may help you pick what sort of strategy you want to utilize to optimize your outcomes. Now, with that being said, there is variability in the positive predictive value. And that's not the fault of the PI-RADS scoring system. The PI-RADS score is a well-validated system that we've previously mentioned, helps in the increased detection of clinically significant prostate cancer. However, the subjectivity lies in the radiologist experience as well as the quality of the MRI itself. For instance, studies have shown that radiologists with over 10 years of experience in reading MRIs have a higher likelihood of calling PI-RADS 4s and 5s over PI-RADS 3s as compared to a more junior radiologist. Furthermore, patients who have artifact in their prostate from UroLift devices or fiduciary markers or brachytherapy seeds may mask and create further artifact that makes it hard to definitively rule in or rule out prostate cancer. And furthermore, if patients have external artifacts such as hip implants, this may also make it hard on various sequences to really be able to know for sure if you are missing cancer or not. Finally, the quality of the MRI machine itself. We've improved from 1.5T to 3T, and there's studies looking at 9T. But of course, in the 1.5T era, the specificity, sensitivity, and quality of the resolution has changed drastically. And so some centers, unfortunately, do not have that 3T or even higher visibility and qualities of MRIs machines. And so it's important to take that into consideration. If you have an external MRI report, what was the quality of the imaging that was done? We know that with that being said, there is a significant false negative rate. Up to 20% of patients with MRI PI-RADS 1 or 2 results have cancer at biopsy. There's also a significant false positive rate up to 50%. And so despite the clear advantage of multiparametric MRI in the diagnostic armamentarium of a urologist, there are still some notable limitations. So the PROMISE study, which came out in 2017, demonstrated that in patients who had PI-RADS 3 lesions, so equivocal lesions, there was still a 79% false positive rate. And conversely, in patients who had a PI-RAD 1 or 2, so an MRI invisible or a negative MRI, there was an 11% false negative rate. Now, this is notable. We can say that maybe this is because at the time, most of the MRIs were done on a 1.5T MRI quality scanner, but at the same time, this reflects real-world practice. If we move to the next slide, we'll see where we are in a more contemporary era with 3T MRIs. So looking at the positive predictive value of multiparametric MRI in a more modern or contemporary cohort utilizing 3T MRI scanners, you can see that the positive predictive value is still quite low for PI-RADS 3 at 13%. For PI-RADS 4, it rises to 40%, and PI-RADS 5, it rises to 69%. But what's important to understand is that multiparametric MRI is not the sole indicator of clinically significant prostate cancer. It on itself is suboptimal, and we have to take into consideration patient age, PSA, what their digital rectal examination shows, PSA density, and that combination and what we call individual patients' clinical risk factors, in addition to their MRI, further aids in the diagnostic risk categorization. So here comes IsoPSA. And we do feel that IsoPSA is a breakthrough in prostate cancer risk assessment for various reasons, and we're going to talk about that today. So before we start talking about what IsoPSA is, it's important to understand that PSA stands for prostate-specific antigen, not prostate cancer-specific antigen. So it is not specific for cancer, but it can be elevated in other prostatic diseases, notably BPH, prostatitis, in patients with recent instrumentation, urinary retention, physical and sexual activity. And so it is a concentration-driven assay, whereas IsoPSA is a structure-based assay, and it's specific for cancer. And so it can help unmask prostate cancer and clinically significant prostate cancer, irrespective of the PSA concentration. And I think what's nice about IsoPSA is that it explores the entire spectrum of possible PSA isoforms. So it does not have any finite isoforms that it explores. IsoPSA is a ratio, and how this ratio is found is through a two-phase aqueous reagent which separates different isoforms of PSA. Now, this test is indicated for men who are 50 years of age and older or have a PSA greater than or equal to 4. So ordering an IsoPSA test takes about 2 to 3 days for the turnaround time. Once you get the results, you will see that there is an important row highlighted in blue. And I want to highlight two important findings that you will see on your IsoPSA result. First and foremost, you will get a PSA result. And this is important because when a patient comes in with an initially elevated PSA, you don't have to reorder a PSA. You can go right to ordering an IsoPSA because it comes with a PSA as well. So for instance, this case here of this man who had an initially elevated PSA received an IsoPSA, and you can see that his IsoPSA was 4.6, but right below that, you see his total PSA was 6.95. And so you can kind of kill two birds with one stone by ordering this. Now you see on the right, it says risk threshold greater than 6. And that is a cutoff that has been shown to be associated with an increased risk of clinically significant prostate cancer. Now, the interpretations at the bottom for new users is that if your IsoPSA index is less than or equal to 6, you have a decreased risk of harboring high-grade prostate cancer defined as Gleason score 7 or higher. If you have an IsoPSA index between 6 and 10, this is where clinical decision-making is important, and it should be based on additional baseline risk characteristics such as a patient's family history, race, ethnicity, other prostate MRI findings, etc. And if the IsoPSA index is greater than 10, this patient has an increased risk of harboring high-grade prostate cancer, which would prompt further evaluation, including consideration of biopsy. And so this is the sort of information you will get when you order an IsoPSA. It's quite user-friendly. So what are the benefits of measuring PSA structure? Well, first and foremost, it simplifies patient selection with limited exclusions. When you order an IsoPSA, you don't need to garner patient history, clinical information. You don't need to do a digital rectal examination. Furthermore, the PSA value that you need doesn't need to be between 4 and 10. It can be as high as 100. Looking at the work from Klein and his group, they looked at patients who had large prostates, small prostates, those with prior biopsies, those who were biopsy naive, and those who had PSAs ranging between 4 and 100. Furthermore, BPH medication, which influences PSA, such as 5-alpha reductase inhibitors, does not influence the IsoPSA, as IsoPSA is a structure-based assay, not a concentration-based assay. And so Scoville and his group published work on whether or not patients who were on Flomax or 5-alpha reductase had any influence on the IsoPSA predictive capabilities for prostate cancer or clinically significant prostate cancer. And they concluded that this was not the case, which is great. Secondly, there's greater accuracy than measuring total PSA concentration. And I think that's really important and a key takeaway, because we know that PSA has a poor specificity. And in a study of just under 900 men looking at PSA values ranging between 4 and 100, so elevated PSA, that IsoPSA was better in terms of positive predictive value, negative predictive value, specificity in detecting not only prostate cancer, but clinically significant prostate cancer. And it maintained the same sensitivity. Now, it was not only better than PSA, but it was also better than percentage-free PSA. You can see that IsoPSA had an area under the curve of 0.78 as compared to 0.72 for percentage-free PSA and only 0.67 for concentration or parent PSA. Thirdly, it improves biopsy decision-making. And I think that's really important when you're having a conversation with your patient. It's extremely helpful when combined with MRIs. We know our patients come to our clinics oftentimes with an MRI already done. And so you can utilize that MRI and the information garnered from it through a PI-RADS scoring system, and you can combine it with the IsoPSA to come up with predicted probabilities that can then be relayed in an easily understandable way to the patient about what their probability of meaningful cancer is today. And this can be done in biopsy naive patients and as well in those who are considering a repeat biopsy. So these are a few ways that you can utilize IsoPSA in your decision-making pathway. Personally, my preference is the top row, and we're going to go through it. Obviously, some people think that getting an IsoPSA before MRI is helpful. Others who already have an MRI can get an IsoPSA after. And that's the beauty of the IsoPSA, that it has value before or after the MRI. And so if we start at an increased baseline risk with a PSA that's elevated and you want additional information, if you start with the IsoPSA and it's greater than 6, this is where you can consider getting an MRI. And you're informing your decision based on that elevated IsoPSA ratio. If your IsoPSA is less than or equal to 6, you could potentially omit the MRI and the costs that come with it. Now, other people may say, okay, well, I prefer to get an MRI before IsoPSA, and that's fine. Personally, that's how I practice. And so if someone comes in with an elevated PSA and you either get an IsoPSA or they come in with an MRI, if the MRI is available, I like to get an IsoPSA because it adds so much information to my conversation with them based on the combination of the MRI and the IsoPSA. So if you see those 3 arrows, if you have a multiparametric MRI that shows a PI-RADS score 1 to 3, and you have an elevated IsoPSA, that would drive me towards moving with a biopsy. If you have a multiparametric MRI that has a PI-RADS score 1 to 3 and a low IsoPSA ratio, that would move me away from doing a biopsy. And we're going to go through the nuances of why that is. And then finally, if someone has a multiparametric MRI that shows a PI-RADS score 4 or 5, you actually don't need an IsoPSA. And we're going to go through the details of that as well. So sometimes getting a multiparametric MRI before IsoPSA, or if a patient comes in and already has a multiparametric MRI, utilizing the PI-RADS score that was provided can help you decide on A, whether to order an IsoPSA, and B, utilizing that combination to decide on biopsy thereafter. So let's dive deeper into the clinical studies that drove my previous slides. And let's go through 4 or 5 cases as well, just to kind of personalize some situations where I find IsoPSA quite helpful. And so this is a seminal paper that came out by Klein and his group in 2022. This was just under 900 men who had elevated PSA and underwent IsoPSA evaluation. And you can see that, as I mentioned before, IsoPSA outperformed not just total PSA, but percentage-free PSA as it pertains to area under the curve. If you look at the table on the right, you can see the area under the curve was 0.78 versus 0.67 for PSA and 0.72 for percentage-free PSA. And they used a cutoff of 6 in this situation. Now, you can see that the sensitivity is still maintained for all 3, but look at that specificity. And this is where it really takes over from not just PSA, but also percentage-free PSA with a specificity of 45.5%. The negative predictive value was almost 90%. And so when you look at these results, a low IsoPSA ratio, so less than 6, has a very strong negative predictive value that the patient that you're talking to will not have clinically significant prostate cancer. Whereas the positive predictive value, although it's good, is not in the 90% range. And so it's important to know that while the IsoPSA index is better than PSA and percentage-free PSA, that a negative predictive value is very reassuring. This is an example of a 58-year-old being treated for BPH. The initial PSA was 6.1, and his digital rectal examination showed a large prostate, but there was no linear firmness or nodularity. The patient was reluctant after doing some research about PSA screening and wanted to talk to you about it. He refused an MRI, which some patients do because of claustrophobia. And there was a discussion about IsoPSA and that how that can help better risk stratify patients with initially elevated PSA. And so he was amenable to repeating an IsoPSA to see what that showed. Now, his repeat PSA was 6.8. And in line with the results, his IsoPSA index was 10.4. So it was elevated. And so this prompted a decision with the patient that we should move forward with biopsy. Now, the patient was claustrophobic, and so an MRI was not done. So what we did was we moved forward with a systematic biopsy, and this showed 2 out of 12 cores positive for gray group 2 disease in this situation. Now, before talking about this slide, I also want to acknowledge the fact that Dr. Klein's study also demonstrated that if you utilize IsoPSA, you can actually reduce the rate of unnecessary biopsies. In his study, it was 42 to 46%, and it could be as high as 55% if you use cutoffs and IsoPSA values greater than 10. And so not only is this superior in detecting prostate cancer and clinically significant prostate cancer, but in those patients who are reluctant to get a biopsy, I mean, you could reduce unnecessary biopsies by about 46%, which is great. So in this study in 2023, this is where the notion of utilizing MRI in addition to IsoPSA is extremely valuable. So this study looked at IsoPSA in conjunction with the PI-RADS scoring system and helping refining biopsy decision-making in men with elevated PSA. There was a total of 207 patients who underwent prostate MRI, IsoPSA testing, and biopsy within a year. And here what you can see in the table on the right was the predicted probability of clinically significant prostate cancer based on the combination of the PI-RADS score and the IsoPSA ratio. Now, what are the 2 important takeaways from that table? Well, first and foremost, what about in the gentlemen who have a negative MRI? Are we missing clinically significant prostate cancer? I mean, we saw from our previous MRI papers that PI-RADS 1 or 2 can harbor between 8 and 20% of prostate cancer that's MRI invisible. So how do you unmask that MRI invisible clinically significant prostate cancer in up to a fifth of your patients? Well, this is where the IsoPSA comes in handy. So you see here in the table, if you have a PI-RADS score of 1 or 2, so an MRI invisible or an MRI negative result, and your IsoPSA index is less than or equal to 6, This reduces your probability of clinically significant prostate cancer to less than 5%. However, if your IsoPSA index is greater than 6, this is increasing your probability of clinically significant prostate cancer to above 5%, approximately 8.5%. And so when you have a negative MRI, the IsoPSA index will help you determine whether you should biopsy a patient or not. Furthermore, when you have that equivocal PI-RADS, which is that dreaded result where you don't really know what to do with it, this is where IsoPSA index comes in handy as well. Again, an equivocal MRI, so a PI-RADS with a low IsoPSA index, less than or equal to 6, the probability of clinically significant prostate cancer is only 4.6%, so less than 5%. So you can omit biopsies in those patients. However, if the IsoPSA index is elevated, that rises to greater than 15%. And so again, this is a situation where the MRI is not really helping you too much, but it's giving you a little bit of suspicion with an equivocal lesion. And you can try to stratify the risk of clinically significant prostate cancer with the IsoPSA index. And then finally, when you have a suspicious lesion or a very suspicious lesion on MRI, I think it's a no-brainer. You should go right to biopsy. I don't think IsoPSA adds much value in that clinical context, but it adds value in the context of ambiguity or if there's an MRI that's invisible or negative. And so again, in summary, a PI-RADS score 1 to 3 IsoPSA is extremely helpful. If a PI-RADS score of 4 or 5 exists, I think you should move forward with biopsy. So this is a 62-year-old male with an elevated PSA of 9.2. He had a big prostate, 60 cc's. So his PSA density was on the fence. I know 0.15 is an arbitrary number, but it's also clinically useful in making decisions on the risk of clinically significant prostate cancer. And his was right on the fence at 0.153. Repeat PSA at 9.9, still elevated, and now his PSA density has risen to 0.165. The MRI, however, demonstrates a PI-RADS, so a negative MRI with multiple BPH nodules. So on one hand, you have a PSA and a PSA density that's concerning, but on the other hand, you have an MRI that's reassuring and kind of making you feel like this patient just has a big benign prostate. So in this situation, we ordered an IsoPSA, and the IsoPSA came back low. As you can see in the blue row on the right, the IsoPSA index was 4.8. So that's lower than the threshold of 6. And in this situation, you have to think about that study we just talked about, where you have a patient with a low IsoPSA index and a negative MRI. So the probability of clinically significant prostate cancer is 4.2%. And you can relay that to the patient to help them with an informed decision. However, in this situation, the patient still pursued a biopsy because they were concerned about the PSA and the PSA density. And so the biopsy came back demonstrating benign findings in 10 out of 12 cores with gray group 1 and 2 cores. And so active surveillance was initiated as per NCCN guidelines. And again, this table is extremely helpful. You can see from the top left result, PI-RADS 1 or 2 plus an IsoPSA index of less than or equal to 6 harbors a 4.2% chance of clinically significant prostate cancer, which is low enough to suggest omitting biopsy in this cohort of patients. Now, this is a 47-year-old African-American male with an elevated PSA. He refused a digital rectal examination at his initial clinic visit, but was okay with repeating a PSA, which came back elevated at 7.3. Now, he had a 42 cc prostate on MRI, and he did have a suspicious lesion. He had a PI-RADS lesion in the right peripheral zone. So the question here is, do you need an IsoPSA? Well, we've discussed that in this situation, the risk of clinically significant prostate cancer is high, and so we should not need an IsoPSA. And we recommended a targeted and systematic biopsy. However, the patient wanted monitoring despite our recommendations. And so what we did is we ordered a PSA and an IsoPSA. His PSA had come back at 7.7, and our clinic had ordered an IsoPSA, which came back elevated at 19.2. And so with this information, and the PSA was 8.4 in line with the IsoPSA. So with this information, we strongly prompted him to move forward with a targeted and systematic biopsy, and he did. And His target came back grade group 3 with 3 out of 4 cores positive. There was cribriform and intraductal disease, and his systematic core was grade group 2 at 5 out of 12 cores. Now, I wanted to point one study that demonstrated that IsoPSA predicts clinically significant prostate cancer with no specific adverse histopathologic preference. And what do I mean by that? It means IsoPSA doesn't predict for cribriform. It doesn't predict for intraductal. It doesn't predict for the percentage of pattern 5 or the percentage of pattern 4. It predicts clinically significant prostate cancer throughout. So it's very, very stable, and it doesn't change with the presence or absence of cribriform or the presence or absence of intraductal carcinoma, at least in one study. And so this is nice for all comers because it's a broad-based assessment of clinically significant prostate cancer. And for this gentleman who clearly has a lot of risk factors, African-American, elevated PSA, PI-RADS4 lesion, the IsoPSA came back extremely elevated and his disease came back significant. Now, if you look at the PI-RADS4 column and the elevated IsoPSA index, the combination yielded a probability of clinically significant prostate cancer at 48%. So pretty much a coin toss. And so this is a no-brainer that you should do a biopsy in these patients. But I want to highlight what the probability of clinically significant prostate cancer would be in someone with an elevated, someone with a concerning PI-RADS score, so PI-RADS 4 or 5, but a low IsoPSA index. It does diminish the probability of clinically significant prostate cancer quite substantially, but 22% is still much too high to not want to do a biopsy. But I just wanted to highlight the point that a low IsoPSA index in this situation over halves the risk of clinically significant prostate cancer. But again, does that warrant ordering it in someone with a PI-RADS 4 or 5? No. So in this situation, PI-RADS 4 or 5, go right to biopsy. So our fourth case is a 73-year-old male. He had elevated PSA at 12.1. He had in the past a prior negative biopsy, but this was over a decade ago when his PSA was 6.5. We repeated the PSA at 11.9. And then when we ordered an MRI, he had a very large prostate, 112 cc's, and he had 2 PI-RADS3 lesions, one in the right transition zone and one in the left transition zone. So what we did with the equivocal PI-RADS score is that we ordered an IsoPSA. Now the PSA came back at 13, but the IsoPSA came back low at less than 6, specifically 5.8. And so again, going back to that chart, if we look at a low IsoPSA with a equivocal PI-RADS3 lesion, the risk of clinically significant prostate cancer is less than 5%. And so we would encourage a patient to avoid a biopsy in this situation. And that was our plan for him. So 6 months later, as part of his PSA surveillance, his PSA came back at 14.2. And given the rise in the PSA density because of the rise in the PSA, the patient was concerned enough that he wanted a biopsy. And so what we did is we performed a targeted and systematic biopsy of both PI-RADS3 lesions and then the rest of his prostate. His right transitional zone lesion came back as benign. His left came back as ASAP, and his systematic biopsy had high-grade PIN and benign biopsies. And so in summary, this patient, yes, he had an elevated PSA, but he also had a very large prostate that could have been well driving his PSA. And furthermore, with the PI-RADS3 and the IsoPSA combination, his risk of clinically significant prostate cancer was low. Now, again, if he had had a PI-RADS3 lesion with an elevated IsoPSA, his risk would have gone from 4.6% to 16%. And so that IsoPSA index would have been the decider for whether or not he gets a biopsy or not. One of our last studies here, this is a 64-year-old male who was on active surveillance. He had an IsoPSA in 2023 when his PSA was 5.9, and his IsoPSA was elevated at that time. It was 8.9. He did have an MRI at that time, which showed a 45 cc gland. He had a PI-RADS 4 peripheral zone apical lesion. He had a biopsy that was done transrectally, and unfortunately it was complicated by sepsis. The target had grade group 1 in 2 out of 3 cores. And then he also had grade group 1 in 1 out of 12 cores on systematic biopsy. Now, as part of active surveillance monitoring, we order PSAs routinely, MRIs, and we do recommend a confirmatory biopsy within 18 months. But he absolutely did not want a confirmatory biopsy because of his experience with sepsis. And so the decision was for PSA trending, despite our recommendations, and that we would perform it transperineal, which obviously reduces the risk of infection. But this was his preference. We then repeated an MRI in 2025, which again showed this ongoing PI-RADS4 lesion, which had previously been biopsied, but it was getting a little bit bigger, and his prostate as well had grown from 45 to 55 cc's. We again recommended confirmatory biopsy, but patient had this bad experience, and so an IsoPSA test was ordered in this context. The IsoPSA came back elevated at 12.3, and recall that it was elevated in 2023. But it was between 6 and 10, and now it was above 10. And his total PSA was 6.8. And so what we did is we planned for a fusion biopsy, and this came back as grade group 2 in the PI-RADS4 lesion. And so because of that, we considered him an upgrade from active surveillance, and we moved forward with focal therapy in this situation. So I wanted to thank everyone for joining us today. I really hope that you guys do see value in utilizing IsoPSA, not just in refining your biopsy decision-making process, but also utilizing it in conjunction with multiparametric MRI to have a real discussion with your patients. And I love the predictive probabilities because it relays a complex message in a way that's easily understandable in the English language to patients who are coming in who just want to know what are their probabilities today of having clinically significant prostate cancer. Should they get a biopsy? Should they not get a biopsy? And you really help them make a decision that's best suited for them when you provide them those percentages. And so with that being said, I'd be happy to take some questions. And I thank you again for taking the time to join us today.
Thanks, Dr. Benidir. We've had a few questions come in during your talk. One is a general question. Would you be able to share a couple of reasons why you use IsoPSA in your practice over other tests?
Absolutely. And so I use IsoPSA in various contexts. I use IsoPSA because PSA is nonspecific. And so if patients come in with an elevated PSA, I really want to utilize IsoPSA to really help unmask what is the likelihood, what is the positive predictive value, what is the probability of them having clinically significant prostate cancer at that point in time. So it just adds one more feather to the hat of a decision-making model. And biopsies, although they have improved from transrectal to transperineal in reducing the rate of infection, they're not without complications of hematuria, pain, urinary retention, discomfort. Some people who have higher comorbidities require anesthesia. And so if we can reduce unnecessary biopsies, I think we're doing patients service. And so the fact that it reduces unnecessary biopsies from 42 to 46%, I think is a great, a great resource that we have. So I use it in those with elevated PSA. I also use it in the context of what to make of the MRI findings. Obviously, if you have a radiologist at your practice who has greater than 10 years of MRI experience and is a fellowship trained GU radiologist, their likelihood of calling PI-RADS3s diminishes. You probably have higher quality MRIs. And so you could most likely rely more on the results of the MRI impression and on the findings. But oftentimes we do get patients that come from outside Gainesville in various communities. They may not have had the best MRIs, also known as the PI-QAL. The PI-QAL is not as good, and that's the quality of the MRI. Or the reader is someone who reads more than just prostates, and so may not necessarily see a lot of prostate MRIs. You want to try to stratify what you see in addition to the biomarker. And I think the biomarker helps a lot in refining who are the real concerns and who are not the real concerns, because MRIs are great, but they aren't perfect. And so who are the patients with a negative MRI who actually have meaningful disease? And oftentimes those are situations where the story just doesn't add up. The PSA is just too high. The PSA density is concerning. And those are just two examples where I really like using IsoPSA. And then finally, I like IsoPSA when it comes to counseling. I think if you get a low IsoPSA in a patient with an elevated PSA, I find that quite helpful. Abdallah published a study looking at patients who have IsoPSA and what happens to them 12, 24, and 30 months down the road. And what she showed was that patients who have an initially low IsoPSA, their chance of having clinically significant prostate cancer 30 months down the road is only about 6%. But if you have a high IsoPSA, what is your chance of having clinically significant prostate cancer 30 months down the road? Rises to 49%. So if you have a biopsy that didn't show cancer, or it was grade group 1, and you potentially want to keep monitoring your PSA as you should, or go under an active surveillance protocol, and your IsoPSA was low, you can feel more reassured that the patient will not necessarily explode with prostate cancer in the first 12 months. But if their IsoPSA was elevated, you may want to keep a closer leash on your PSA surveillance and your MRI surveillance. And you may want to potentially get a biopsy sooner.
Thank you. Here's another question. How much additional work will my staff have to undertake when I order an IsoPSA test?
So that's a great question. I want to say it's probably center specific, but at the University of Florida, we've been fortunate enough to have the IT department add it to our Epic software. So Epic is the software that we utilize online for ordering. And so it's as easy as searching in your toolbar on Epic and writing IsoPSA and placing an order. And at that point, the turnaround time is 2 to 3 days before we get a result back, which is excellent. And so if you can incorporate it in your workflow, for instance, if you have Epic, it's as easy as ordering a PSA or a CBC or a creatinine, for instance.
Good. In your practice, for those patients who you've obtained serial IsoPSAs, have you ever observed a patient who's had a significant decline in their IsoPSA over time?
Outside of clinical trials, I want to say that I utilize IsoPSA during my surveillance, and I have not seen variability like we see with PSA. And IsoPSA can go up, but it generally stays at a certain threshold. So if you have, for instance, an IsoPSA of 6 and you repeat it again in 3 to 6 months, it's not going to suddenly go to 1 or 2. It's going to stay around 6. But if you keep monitoring patients, you're going to see either a stable IsoPSA or you're going to see an IsoPSA start to rise. But it's extremely rare to see an IsoPSA decline unless you've treated part of the prostate, for instance, through focal therapy or something like that. But that's, outside of guidelines and more clinical trial setting. But for the vast majority of when you use IsoPSA, it usually stays very stable or rises.
So we have a case from one of the webinar participants. How would you manage a patient who initially presented with a PSA of 4.9, who went on to have a systematic biopsy by another urologist? All of his biopsies came back without evidence of prostate cancer. He has since had an IsoPSA, which came back at 4.1. How would you counsel and manage this patient? He's anxious about missing prostate cancer and would also like to avoid another biopsy.
Yeah, so maybe this question came in, before I discussed the Abdallah paper, but I think that would be a great resource for that specific person to review, or I can just tell them that this really helped me out. So if a patient has a elevated PSA, but a biopsy is benign and their IsoPSA is low, what you can do is you can at least counsel them on their 30-month risk of developing clinically significant prostate cancer. And in that context, that person's risk is 6%. And the difference is if they had an elevated IsoPSA, but a negative biopsy, their risk of developing clinically significant prostate cancer in the 30-month span would be 49%. And so I would counsel them that I'm very much reassured by the IsoPSA, and I would feel comfortable getting PSAs every 6 months to a year rather than every 3 to 6 months.
Okay, one last question. For your men who come with multiparametric MRIs up to 3, with elevated and rising PSAs. Would you get an IsoPSA in all or most of these patients, or are there patients you would avoid it in?
I would prefer to get the IsoPSA in patients with negative MRIs that have high PSA and in the equivocal cases. So to answer your question in short, yes, I think that's the ideal patient population to get the IsoPSA. And I think, IsoPSA has its place in ambiguous context, when we're not really sure what's going on. For slam dunks, like a 2.5 centimeter PI-RADS 5 lesion with concern of EPE. I mean, what other adjunctive test do you need? It's screaming at you that it's cancer, or that it warrants a biopsy. A PI-RADS 4 is suspicious. It's shown on various sequences of MRI that it's concerning. And so you need to get a biopsy, but it's in those equivocal or negative cases where IsoPSA truly has a home.
Thank you. At this point in time, we do not have any more time for additional questions. I'd like to thank Dr. Benidir for his compelling and interesting talk and in really helping to understand how IsoPSA can provide additional useful information for our patients. Thank you, Dr. Benidir.
Thank you so much for the invite.